RBP for resistance training, cardiorespiratory fitness, and flexibility training. There are some differences in the book versus this lecture. The book does these separately, right? There's a chapter on CRE, the chapter on resistance training, the chapter on flexibility, but the programming approach is similar. So we're going to talk about them together. So for example, you would do a needs assessment on somebody regardless whether they're doing CRE or RT. So we're going to talk about that together. The goals of these three, of CRE, of RT, of flexibility training, should all support each other as well. The relevant tables or figures are in this week's Blackboard content folder or are a blank handout for you to follow along. So there's some where it says handout, and those ones I provide the whole thing. And some it's just a table, and I have the table on the slide, but I also have a copy of the blank tables not filled out, so you can just write those in. So for example, what I just talked about there, this is a figure that's not in your book. So that is here, and then you have a handout with blank tables so you can fill in the tables. Let's do a quick review of energy production. ATP is a high energy molecule. The storage of ATP is limited, and we produce it through one of three ways. Do you remember what those three ways are? Creatine phosphate, CP, immediate ATP source, it lasts about 10 seconds. We have anaerobic glycolysis, which is a faster source. It lasts about 90 seconds. It breaks down glucose or glycogen into pyruvate. And we have our oxidative system. It's a slower source of ATP, but hypothetically it lasts indefinitely. It requires oxygen to facilitate the Krebs cycle and electron transport chain. So when we are doing our exercise prescriptions, our EXRX, we need to consider which energy production method we want to train and or stress. So for example, with creatine phosphate system and exercise training, that system is going to last no longer than 10 seconds. Exercises training anaerobic glycolysis are going to be a little lower intensity, and they last about 1 to 3 minutes. And if we're training our oxidative system, it's going to be even a lower intensity because this is a slower source of ATP. Before we get going, let's get on the same page for some vocabulary words. I was really disappointed. I came into Game of Thrones like on the 4th season, and I thought the show was about Ned Stark. So I was pretty devastated after the first season. I've moved on now, so we'll move on to the lecture 2. All right, basic terms, reps. This is how many times you perform each exercise. There is a specific intensity for this, and we will refer to this for resistance training or cardiorespiratory fitness. Sets are how many times you perform the specified number of reps. And again, we use this if we're talking about free weights, stacked weight machines, dumbbells, barbells. We're doing CRF with time or distance. So for example, 2x12 seated leg press, 3x10 dumbbell arm curl. That is 2 sets of 12 reps, total 24 repetitions of the leg press. 2 sets of 10x200 meters at 800, 80% of heart rate max. I don't want to do 800% of heart rate max. I don't know about you, but that sounds awful. 80% is hard enough, right? Okay, so again, sets, reps. Anybody know what EIMD stands for? It's exercise-induced muscle damage. This is increased muscle soreness and swelling. It tends to be an increase in intramuscular, that's what the IM stands for, proteins in the blood. Relevant to our training prescription, somebody who has EMID is going to have decreased force production. This is most frequently due to novel exercise, eccentric focused exercise, and a custom exercise, which could include an increase in load or a change in type of exercise. Maybe you move somebody from stacked weight machines to free weights. It includes DOMS, but that's not the only type of EIMD. So every time we go and lift or do a hard workout, we're going to have a little EIMD. We're just going to have a little muscle damage. It happens. But when it's really severe, that's when we have the delayed onset muscle soreness. So this is a more serious type of muscle damage. It can lead to rhabdomyolysis, which is not good. Rhabdo usually is just abbreviated as, so it's kind of a hard word to say. So that's really serious. We can have more mild DOMs where we're not that serious. We just still have some limitations with that. So this is the type of soreness that peaks about 24 to 72 hours after exercise. You know how like you work out and then the next day you're in the shower and you have to like bend your head down to wash your hair because you can't lift your arms up to wash your hair. So that's DOMS. There's more damage. Now we're not quantifying this, nothing we can really use to numbers, but it's just relatively speaking, it's more damage. And because it has a bit of a protective effect, your muscles are like, I have a lot of damage. I need to take some time to repair this. And so I'm going to enact this protective effect. The joint angle is going to be a little limited from the swelling. You're not going to be able to generate as much force. You're not going to be able to do as much damage again, hopefully, soon with this. What we generally aim for is supercompensation, though. We're going to use this in the context of the general adaptation syndrome. If you've had psychology or if you've read that in the book, you may be familiar with this in terms of psychological stress, but we can also use it when we talk about physical stresses like exercise. There are 3 stages to the general adaptation syndrome: alarm, resistance, and exhaustion. So alarm is when we have a new stressor. In the case of exercise, this is when the overload principle is performed or applied. And then we enter the resistance stage where we adapt to the overload. And then we go into either exhaustion, which can lead to overtraining, or when properly planned, because you've taken my awesome class, instead the athlete will go into supercompensation. So instead of exhaustion, they'll go to supercompensation, which is a new baseline. This will make a little more sense hopefully on the figure I have on the next page. So we use these principles when we do periodization workouts. We're thinking about when our alarm stage is, how much resistance they need, how much time they need to adapt to the overload, right? And then we'll retest them with supercompensation because they have a new baseline. So here's the figure I like to use. This is on the handout in Blackboard. You don't need to copy this down. I mean, you should in your notes because it's good practice. But as far as little details, you have this. So we have somebody starting here with their performance level on the left, and this is their current baseline. And then we apply an overload, the alarm state phase, and there's a slight decrease in performance, but we have properly planned for this. And they enter the resistance phase where they're adapting. And then number 3 appears, supercompensation. We have a new baseline fitness. Now, if we didn't do a good job, or maybe the person needed more time to recover or something, then instead the person is going to go into overtraining and their performance is going to decrease even more. Once we're up here with our new baseline, we can repeat this. We can induce a new stressor again, new overload, dip in performance, and then as resistance stage occurs, they increase and have a new baseline, a new supercompensation again. Okay. Moving on to periodization. With periodization, we vary the intensity and volume of training. This maximizes the response of the neuromuscular system by systematically changing the stimulus. It also helps us minimize overtraining and injury. We can manipulate frequency, intensity, volume, type of contraction, type of apparatus used. So we have 3 types of cycles. There's our macro cycle, which is our overall big picture. And then within that, we have our next layer is the mesocycle. And then our last smaller one is the microcycle. I'm sorry, micro with an I, microcycle, make sure I said that right. So macrocycle is usually 9 to 12 months. For elite level athletes, it may go as long as 24 years. 24 years, holy moly. That's a really long macrocycle. 24 months, which is 2 years, because a lot of competitions at the elite level happen every other year. So for example, World Cup, that happens every 4 years. And then the Olympics also happen every 4 years, but it makes it so that the World Cup or Olympics happens every 2 years, right? There's other competitions that are like that as well. The Olympics are every 4 years, and the other type of games are also every 4 years and alternates for that there's something huge every 2 years. We have our mesocycle, which is 3 to 4 months. What does 3 to 4 months sound like? Like, especially if you're talking like high school or college athletes, what's that sound like? It's a season, right? So we have our preseason, our postseason, our in-season, our off-season, and that would be our 3 to 4 month cycles. And then we have our microcycles within it. So what are our key events within the season? Are we going for some key games, maybe big rival, maybe a conference championship, and then nationals a couple weeks after that? And that's going to determine our microcycles. Well, obviously, we can do this with our general gym goers as well, because we want to vary their training also. We just may have different goals for them. We're not training them for a postseason, but we might be training them for a 5K or just at a point where they want to peak, and then we'll come back down. A lot of people, like I have a friend who likes to peak around his birthday so that he can lift a lot on his birthday. That's one thing that people may use as a guide for where a point should be. And also people can just do their exercises. We're still going to vary their cycles throughout their exercises if they're not training for anything in particular. Our 3 main periodization types are linear, reverse, and undulating. And it has no pyramids, because it's not like a straight up and straight down. There's ups and downs along the way. It's very jagged. In classic linear periodization, the intensity increases while volume decreases. Typically, this means it'll be higher weight with less reps. You can also increase the sets to manipulate the intensity. So you have a high intensity but low number of sets, or low reps with higher sets. Can also happen. Lots of ways to get the correct answer on this. So if linear periodization is increasing intensity while volume decreases, what do you think that means reverse linear periodization is? That's right. Increase intensity decreases while volume increases. So typically lower weight, more reps, and the sets may change. Towards the end of the lecture, I have an example of where we do these together in a training plan. The third one we're going to talk about in this class is undulating periodization. Does anybody know what undulating means? It means rolling. So these are rolling short microcycles. They can be bi-weekly, weekly, or even daily. It helps the person avoid plateaus, helps them maintain interest. It's good for the client who bores easily, because we're switching up a lot. So for example, on Monday, they would lift to a weight that corresponds to 8 RM, on Wednesday to 6 RM, Friday 4 RM. We can also do this with our cardiorespiratory fitness type exercises as well. When we apply periodization, we're going to think about, if it's an athlete, their prep phase, their competition phase, their transition periods. This is the difference between ACSM and the NSCA CS exam. So the ACSM is mostly concerned with general fitness and reducing cardiovascular disease risk factors, whereas with the NSCA CS exam, it's more towards working with athletes. Now, obviously, you can have a CS and work with a general population. I find their guidelines to be a lot more specific in terms of goals, as opposed to just let's increase somebody's cardiovascular fitness. But they talk a lot about these prep, competition, transition phases, and ACSM doesn't really talk about that at all. But lucky you, I have both certifications. So I have studied both and trained in both and applied both. Right, so our preparatory phase is our off-season or base phase, and that moves to pre-season. All right. So this is a base level of conditioning. We start with general motor ability and skills. As we move towards pre-season, we're moving more towards sport-specific training. Our sport-specific training is going to peak more in our in-season. Competitive, also known as the in-season phase, is a delicate balance to increase fitness while performing at a high level. We don't want to lose. We don't want to be putting the athlete at risk of injury because of too high of intensity and volume of training. And then in off season, this is our active rest. The goals for off season are going to depend on what the person needs to work on. And then we have transitions between these stages where we're changing from our previous goals to our new goals. This figure is also in your handout, and it just shows how we have this together. So we have our prep phase, which is moving towards our pre-season, and then our in-season or competition phase. So training technique is low, it's going to peak while we're in season. So when we're in our prep phase and our transition phase, we're more concerned with the fitness as opposed to the specific technique. Volume of training is high in the prep phase. It decreases as we go through pre-season and working towards in season, and again peaking. We have our decrease. We're going to make up for that low volume by having a high intensity or higher intensity of training as we go through the pre-season from the prep off phase, and we're going to increase the intensity. And then as we move into off season, pretty much everything decreases. Again, it depends on the goals of the person, but broadly speaking, that's what we do. We're into talking about training. Let's talk about some principles of training. There are 4 principles of training we're going to discuss. The first one is progressive overload. What is progressive overload? This reflects the need for exercise to be greater than the accustomed to induce adaptation. If we want somebody to improve their fitness, we're going to need to increase the load. So overload in the sense that it's more than what they're accustomed to doing. Not overload that we're going for as high as we can, but just more than the person's accustomed to do. Next up, we have reversibility. There's a colloquial name for this. Anybody think of what it is? So reversibility is the use it or lose it principle. It represents the opposite of overload, in that if we are not overloading, if the person is not doing greater than they are accustomed to, then they will decrease their fitness. The principle of individual differences, and this recognizes that the same stimulus can produce very different responses within individuals. I'm use an example of my running partner. We both train very similarly, right, because we're running together, but I'm a little bit faster at a 5K than she is. Now, that's not to say I'm fast at a 5K. I am faster than her at a 5K, right? Which makes it sound like I'm 5K champion here. So we just respond differently to the training. She's like 4 inches taller than me too. She should be faster than me, but I'll take it. Right. Specificity is our next principle. This states that the specific exercise elicits specific adaptations, creating specific training effects. Is that enough specifics for you for specificity? So if we are training for a marathon, that's different than training for a 100 meter. So we're going to adapt to long distances, but not to the short sprints. So we need to make sure we're training for the events that we mean to. All running is not the same, right? All lifting is not the same. Specific to what we are training for. FIT VP is what ACSM uses to outline the training program. So it stands for frequency, intensity, time as in duration, type as in the mode of exercise, volume or the amount, and P for progression, advancement, or maintenance. You'll see older texts from ACSM and they'll refer to mode and duration, not time and type. So this is new. They like the little acronym, which is helpful. So when we have our steps for developing a resistance and exercise training program, our FIT VP is going to be embedded within that. And there are 7 steps. They don't necessarily all have to be in order. They do work together, so you're going to have to think about them together once you have the person's goals. So there's the needs analysis. That one should be first, because we need to know what we're designing the program for. So needs analysis should always be first. Then we're going to work on exercise selection, training frequency, the exercise order, training load, intensity, and repetitions, volume, and rest periods. So after we get the needs analysis and the exercise selection down, we can deal with the rest of them together. So before we do this FIT BP, this is where the needs analysis comes in. If the needs analysis, we have other conversations to occur. So obviously, let's say the person's already done their pre-screening, they're good to go. Needs analysis is different than that. So this is the evaluation of the person's sport or activity. It includes an assessment with appropriate exercise testing. We're going to determine the degree of experience, especially for resistance training for the person. And we're going to use this information to make the plan individualized and specific. You can design a beautiful exercise training plan for somebody to do a half marathon, but if they came to you because they want to compete in physique competitions, that's not really going to help them much, right? So we need to make it specific and individualized to the person and their goals. This is also a good time to discuss barriers to exercise. So why, what could get in the way of the person being successful with their exercise, and how are we going to help them strategize around that? This is a blank table in your Blackboard folder. So I don't have this filled out. You'll have to fill it out on your own, either with that or however you like to take notes. This part is the resistance training experience classifications. We classify people as beginning, intermediate, or advanced. And there's a little bit of judgment calls we have to make with this sometimes. So for example, generally a beginner is someone who's not training or just starting, they've been doing it for less than 2 months, 0 to 2 days, low training stress, and they have minimal skill. Now, what if you had somebody who was on the stacked weight machines? They've been doing them for 2 years. They'd be coming in, say, 3 days a week. Every Monday, Wednesday, Friday, they were on the stacked weight machines. So they're currently training. They've been doing it for more than a year. They're doing it at least 3 days a week. They've been working their way up. It's a pretty high training stress, and they have a high amount of skill for the stacked weight machines, right? If they came to you and said, you know what, I'm really bored. I feel like I have good strength. I really want to learn powerlifting. That's my goal for the next year, is learn powerlifting. The resistance training experience for powerlifting is beginner, right? They have not been doing training with it. They are fitter than the average person that's coming to start a training program with us, of course, but they have a low technique or skill with the power lifts. With exercise selection, what do we want to consider? There's several things, right? With the exercise types we're having them do, it's all going to be either multi-joint or single joint. Now with sports, multi-joint are considered the most important. Why is that? Most sports are multi-joint activities, right? I can't really think of a sport where you're only using one joint. So we're going to consider sport-specific exercises, muscle balance, specifically the agonist, the main muscle, versus the antagonist, which is usually the passive muscle. So no, I didn't say inactive, I said passive. And we want the proper ratio between the agonist and the antagonist. It's not necessarily equal. It's going to depend on which pair we're looking at. You can look that up. I think it's in your textbook. If not, it's easily found online. We want to consider recovery. What type of light exercises for that? The availability of equipment and facilities, especially for resistance training. And how much time does a person have per session? So again, we can design a beautiful training plan, but it takes 1 hour a day, 5 days a week. The person tells you that they have 30 minutes or 6 days a week. It's not going to work for them. We're going to need to come up with something that's going to work for them. Our general training priorities for resistance training. In our off-season or base, we have low sports practice, high resistance training. And initially with our resistance training, we're focused on hypertrophy and muscular endurance. And then later, as we're approaching preseason, strength and power. Once we're in preseason, a little bit more sports practice, a little bit less resistance training stress. And we're going to start working on sport and movement specific activities. Once the person is in season, we have a high amount of sports practice. Our resistance training stress is going to be lower. And our main goal with resistance training is maintaining the preseason goal. Postseason is going to vary, depend on where the person's at, what they have coming up next, if they need to recover or not. They have weaknesses we need to address. So that's going to vary a little bit. the training frequency. It's gonna be a little bit different if we're talking about resistance training or cardiorespiratory exercise training. The training frequency is the number of training sessions in a given period. For resistance training, beginners 2 to 3 days a week, intermediate 3 to 4, advanced 4 to 7. Now, of course, I think most people realize that we don't want to lift the same muscle group 2 days in a row. So how are we doing 7 days a week with that? Well, with our beginners with 2 to 3 days, we're going to be doing whole body exercises usually. But with more advanced people, we're going to do split routines, different muscle groups on different days, chest, back, legs, auxiliary lifts, stuff like that. For cardiorespiratory fitness, we're going to have undulating intensities and target for our resistance training. And of course, our resistance training frequency is also going to vary with this on or off season, training load, exercise type. With our cardiorespiratory exercise training, frequency is still the number of training sessions in a given period. We're going to think about, if this is our general fitness seeker, what are our ACSM recommendations? So 150 minutes of moderate, 60 of vigorous. How many intense days we have versus movement days. So we don't have sedentary days, even if it's an off day for the person, they're still moving. We're still reducing sedentary time on their non-movement day, their non-intense days. The same thing, beginner average fitness seeker start 2 to 3 days a week, work up 3 to 4 days a week, and hopefully as the person gains fitness, we can work them towards 4 to 7 days a week. That's our goal, right? ACSM says a moderate intensity, at least 5 days a week. And again, we're going to have undulating intensities and target based on the goal for them. Especially if we're talking about somebody who is training for something, the training frequency is going to vary whether they're on or off season, what the training load is, what the exercise type is. There are a few ways to do exercise order. There's a few philosophies based on goals, etc. Generally, though, we do a warm-up. Then we do the primary target. So if the person is interested in strength, we do that first. There's endurance, we do that first. Then the secondary target, if there is one. Then the auxiliary exercises, core, agility, maybe balance, and then a cool down. This is with our general fitness goers. We might do balance earlier in special populations. And exercise order for flexibility, fit it wherever it aligns with goals. Generally, for a lot of people, it's part of the cool down or a bridge between auxiliary and cool down. Sometimes we also do it as part of the warm-up as well, as a bridge between the warm-up and our primary target, especially with cardiorespiratory exercise, right? We'll do some dynamic stretching before doing cardiorespiratory exercises, and maybe even before resistance training as well. That's getting more recognition, which is good. Exercise order, resistance training, same thing, several philosophies based on goals and whatnot. Generally, though, we have people doing power activities first, then other multi-joint, and then single joint. With beginners, we can have them alternate upper body versus lower body. So you have them do a whole body exercise, and you want to make sure they're not doing 2 muscle groups in a row. If they alternate upper and lower, that's a good way for them to not have to know what muscle groups they're working and still alternate. Same thing with having them do push and pull exercises. This can be done with anyone, but it's also good with beginners. So tell them, you're thinking about, are you doing a pushing exercise with your body, or are you pulling? And alternate that. Try not to do 2 push in a row or 2 pull in a row. Or not try not to, but just please don't. We can also do supersets. We work the agonist and the antagonist. That's another way to do push and pull type things. And we have compound sets, which is brutal, but effective. 2 exercises of the same or overlapping muscle groups. So maybe having somebody do a chest press and then a tricep extension. So tricep heavy in both of those, or a bench press and push-ups. Training load and repetitions. When we're talking about load, we're talking about intensity. If somebody has a higher load, we're going to have them doing less reps and vice versa. If they have a lower load, they'll be doing higher reps. Prescriptions using intensity are relative exercise prescriptions. The relative intensity will remain similar. If they're doing, so for example, if you're having somebody do 70%, because that aligns with their goal of 70% of 1RM, then it's relative to their 1RM. They're lifting 70% of their 1RM. As they get stronger, the weight is going to increase, but they're still lifting 70% of 1RM. That relative amount is the same. If you're doing absolute loads, then that's going to change. So if you're saying, all right, we're going to lift 100 pounds, and then in 2 weeks, all right, we're lifting up to 110 pounds. Same thing with, I'm using it for heart rate max, percent heart rate max, for example, right? If you're having somebody doing 70% of heart rate max, and at base, maybe they're running 11-minute miles, and then they did a 12-week training program, and you're awesome, and they did really well, and they were committed to it. And now they're running a 9-minute mile at 70% heart rate max. Something else to consider with resistance training is when to increase. We generally use the 2 for 2 rule. I kind of joke it should be called the 2 for 2 for 2 rule, the way that it's presented, but 2 for 2 rule. It helps us avoid 1RM testing too frequently. So when somebody can complete 2 reps over the goal number of reps for the last 2 sets of the last 2 sessions, it's time to make an adjustment. And if somebody's in maintenance, we can be less aggressive with this. This way we know their 1RM has increased because they can lift more than they were, and we can just increase their weight without having to 1RM test them again. Now, you may have clients that are like my research participants sometimes, where they realize that this is what you do to them, so they start sandbagging it, and you're supposed to be doing 15 reps, for example, and you'll notice they're doing 14 reps for like 2 weeks, and they're totally fine doing those 14 reps. Then you just go ahead and bump them anyways, because they're just trying to not do a little higher intensity workout. With cardiorespiratory exercise, we generally have the 10% rule, which is an increase of no more than 10% each week in volume or whatnot. If it's a beginner, they might be able to do a little bit more. For example, if you're having somebody start off with 2 miles for a long run, and then 10% increase would be at 2.2 miles. That's not even a quarter mile. That's not very much. You could have them bump up from 2 miles and 3 miles. They should be able to do that. And then that's a 50% jump. If they're doing all their workouts in the week, and that should be fine. Regardless of whether we're doing cardiorespiratory or resistance training, we want to make sure we have what's colloquially known as like step down weeks or step back weeks. There's other terms for this, which is where we have a week where we lower intensity and volume, get some good recovery, and maybe it's after a really hard week, or sometimes depending on your training philosophy, right before a really hard week, just allows a little extra recovery so if this person can continue to perform at a good level. Our load and goals for resistance training is going to vary based on load, and goal reps are going to vary based on the goals. So if somebody has a goal for strength, their load's going to be 85% of 1RM at least, with reps corresponding that are 6 or fewer. For power, if it's a single effort event like shot put, let's say, then a little higher load, 80 to 90%. If it's a multi-effort event, so they're repeatedly having to use power, then a little bit lower load, but higher reps, because they're having to train them to do power at a higher, at a repetitive thing. Skeletal muscle endurance, loads usually no more than 67% and at least 12 reps. Let's talk about cardiorespiratory exercise for high performance athletes. So again, we have our off season, preseason, in season, and postseason. And similarly to with resistance training, we're developing a sound conditioning base and then working towards sport specific performance. Frequency is going to vary. Duration of the bouts, the sessions is going to vary as well, as of the intensity, of course. So once we're in season, we're training low and racing in high intensity. And we need to be mindful. So when we're in season, that they're maintaining the gains that they made during the preseason. Some endurance sports are really long seasons, and you're still, what other sports would be in preseason still, you're doing season. You're still working towards the in season. Swimming is a good example of this. They have short course and long course. There's not really a lot of off time in swimming. Whereas other sports, you have more of a true season, like soccer, for example. They have a little bit more of a true season. How are we going to calculate training zones? There are several different methods. Heart rate reserve is the one that's recommended by ACSM. It's the one we will use in this course. We can also use a percent of heart rate max, VO2 reserve, which is the same as heart rate reserve. Or it should be the same intensity, percent VO2 and percent METs. Clinicians love METs, exercise, training. We tend not to use those as much, but you do see that frequently and the clinical side of things. This you have a handout for, right? It says handout at the top because that's letting you know that the table is all filled in and everything. So how are we calculating zones? We have very light, moderate, vigorous, near maximal effort intensity for cardiorespiratory exercise training. And then we have, depending how we're doing it, whether we're doing heart rate reserve, we're doing max, we're doing absolute METs, or, and then also here we have a little column for resistance training. That's per percent, 1 RM for the resistance training. And then we have what percent we would use for each one of those. This is useful. These type of questions that ACSM and whatnot likes to ask. So heart rate reserve method, training, calculating heart rate zones. So with this, we have heart rate max minus heart rate rest. That's your working heart rate, right? Can't go higher than your max, can't go higher than your rest. So what is in between? That's the work you're working at. So you're gonna take that working capacity, multiply it by the exercise desired, let's say it was 70%, so by 0.7, and then add heart rate rest back in. So it's what additional are you doing above rest? I like asking this question. ACSM likes asking this question. You should memorize this equation. You will have one question of this on the exams for sure. With our high performance athletes, we're usually training to lactate zones instead of heart rate. We may use the lactate zones to find the corresponding heart rates. We're not going to do the percent heart rate reserve. We're going to correspond the heart rates to what their lactate is. To do this, though, we need actual lactate tests in the same mode as the athlete's mode. So if the person's a swimmer, we're going to do it in the pool. If the person's a runner, we're going to do it on the treadmill, and so forth. We're going to make these lactate threshold workouts so that we can increase lactate threshold and decrease lactate at a given workload. There's still debate on exactly how to use absolute versus relative lactate concentration. There's some methods coming up. Just know there's still debate among exercise physiologists about exactly how we should do this. This is on your handout. This is one method here. So high performance athletes, we have 5 training zones. We have training zone 1, which is below lactate threshold 1. Training zone 2 and training zone 3, which are the lower and upper halves between lactate threshold 1 and 2. Then training zone 4, which is at lactate threshold 2, and then training zone 5, which is above lactate threshold too. So with this method, if we take an average of people's lactate threshold, this is what we're going to end up with for these two thresholds. And so where is the individual person? What's their power? This example, it's power output. That's really easy to do in a bike. It could be heart rate. It could be some other measure, but power and heart rates are two common ones. So where is their heart rate at 2 millimoles lactate, and where is their heart rate or output, work output at 4 millimoles? And then we can set our training zones that way. This is a table representation of the previous figure. This is also in that handout. So that T1, that before lactate threshold 1, that's light aerobic, and it goes all the way up to maximal aerobic above lactate threshold 2. And this tells you about where the blood lactate would be for each of those zones. What the heart rate max would correspond to, a percent relative to heart rate max or VO2 max, and then what the RPE would be. The duration is about how long somebody could hold it at that. This is if they're trained. Like, you have to be pretty much a beast to be like 60 minutes at your threshold, lactate threshold 4. Yeah, I'll just say that. Another way to do lactate threshold workouts is to do it relative to the person's lactate threshold. So we're not going to use this whole average type thing. We're going to find what their lactate threshold is, and then based our training zones either as a percent below or above that threshold. Then we have what the RPE corresponds to, suggested time they'd be able to hold it, and suggested pace if it's running. I'm going to show you a figure of how we can do some lactate threshold training. This is not mine. I'm not this steady on it, but if you're going to post your stuff to the internet, I'm going to borrow it for this. So we have warm up down here, right? Starting, so low zones, the colors kind of indicate different zones. It doesn't correspond exactly to the zones I just showed you, but just kind of imagine increasing zones, right? Deep red, higher workout. Green, not so much. So we have a warm up here, just kind of basic warm up, getting warmed up. And then we're going to do some increasing intensity sprints to get a nice dynamic warm up, get a little recovery. We're going to increase up to what our first working threshold is going to be. And we have this work to rest ratio of about 1:1. Intensity, I'm going to go up and down. I don't know what happened here. The person dropped their water bottle. I don't know. And then as the workout goes on, we're going to still keep our 1:1, but it's a little bit higher, you can see, than where we're here. So here we're at the bottom of the orangey red. Here we're in the middle of the orangey red. And but still our 1:1 work to recovery ratio, excuse me. And then we want to finish strong with some maximal effort exercise. And so there's a good recovery period. And then we're going to do these repeated high intensity. So you'll notice we have a high intensity spike and then back down. And if we look at these for the work to rest ratio, it's about 1:3, right? For if this is 10 seconds at work, this is going to be 30 seconds rest or recovery. I'm saying rest, recovery, still going at this, right? And we do several of those, and then we end with an all-out max effort, and then serious recovery here at the end. Training volume. This is, if talking about resistance training, the total amount lifted in a training session. If it's cardiorespiratory exercise, we can do that several ways. We can do minutes, is the most common way for that. But there are other ways. We can do METs is another common one. I usually just think about it in terms of volume, but in terms of minute, but you can do what makes sense. The training volume, we're going to decide if this is a single set. Somebody's untrained early in the training session in season, some types of special populations. Sometimes somebody tells you they only want to do one set of something because they get bored, but we know that they need to be doing more than one set. So we can change type of contraction or the modality on it. We can have them do the exercise on the stacked weight machines and as free weights. Higher volumes are needed for further increases in strength. There's evidence that about 3 sets sub failure is better gains than 1 set to failure. I have a question mark after this. That to me seems to suggest that the body better adapts to 1 set. I don't know. I don't have good evidence for that. That's why there's a question mark there, but I'm just throwing that out there. You don't have to know that thing with the question mark. I'm just offering my perspective on it. Volume for resistance training. Again, the reps and sets are going to be based on the training goal. Our average fitness seeker is going to do 8 to 12 reps, 2 to 4 sets, consistent with their individual goals. If they want a little more endurance, towards the 15. If they want a little more power, strength, then towards the 8. Rest periods. Inter and intra set rest. So the recovery between the sets and between the exercises. Intra would be between the same exercise. So if you're doing 3 sets of bench press, your intra. So the intra set rest. Inter set would be between the exercises. So strength and power, heavy loads generally need more rest. There is some evidence that for hypertrophy, a short to moderate rest, so right before full recovery is achieved, may be the most beneficial for hypertrophy. That's just what the research currently supports. Muscular endurance tends to be very short rests, often less than 30 seconds. And of course, we want to cycle the programs. We can't always train or perform at a high level, whether we're talking about cardiorespiratory fitness or resistance training. So we have periodization, of course. And as a reminder, this term is frequently used for resistance training, but we can still apply these concepts to CRE training as well. Our book usually has the average resistance training program, kind of like a beginner strength athlete, typical gym goer, average person interested in strength. It's also good for special populations. Now, there might be some slight modifications that are required as we go through several special populations in this class. We'll talk about what those are. It's also good for youth, older adults, post-cancer treatment, which are all technically special populations. It's just anybody who potentially needs a modification. Something else we want to talk about, and we'll talk about this a little bit more with our lifespan, but sarcopenia. It's typically associated with older adults, but they don't have to only be. If somebody has a chronic disease, they can have sarcopenia or they're recovering from a chronic disease. It's a decrease of skeletal muscle mass and function. And we're concerned about this because if somebody has increased sarcopenia, then that means that they have a greater likelihood of developing physical dependence and, of course, mortality. And ideally, the goal is to not just live long, but to live long independently and be able to do the things we enjoy. I want to talk about this figure. It's from an article by Stone et al. From 2006. And this is a power lifter, I believe, or some sort of strength lifting type athlete. And they have 2 main competitions during the course of their seasons. We have this about 50-ish week long. And so that's about a year with that. So there's 2 main competitions. There is their national championships and their Commonwealth Games. Those are kind of like Olympics for former Commonwealth countries. So think about like Great Britain and their countries, not us. We were the originals that broke off, so we don't do the Commonwealth Games for other countries. Anyways, the orange line, the one that's not filled in, that's training intensity. The purple line, the one that is hashed down here, that's volume. So notice here in the preseason, we have a high load, low intensity. As the season progresses, we move into from our base training to our preseason.
moving from off-season to off-season, moving from off-season into preseason. We have an increase in intensity and a decrease in volume. So we have our big macro cycles, the whole year here, and then we have our mesocycle. These are like about half year each, and then our microcycle is about 4 to 6-ish weeks long. And so within these microcycles, we'll have the person is increasing their training intensity, and they hit a peak and they decrease their intensity a little bit, and that's where the volume spikes. They go back down with the volume, and then they, as they increase intensity, and then again, once we have this increase in volume, there's a decrease in intensity. This goes throughout. Right, for their key competitions, there's a decrease in both volume and intensity to allow them time to recover. And then right afterwards, they pick back up, have some intense training to get ready for the next stage. Exercise prescription lecture. We're going to start with exercises to improve cardiorespiratory fitness. So we will be doing cardiorespiratory exercises for this. As a reminder, a lot of times we'll see this being referred to as aerobic exercise, but it's not really true, because even when we're doing an aerobic dominant exercise, there's still some anaerobic processes going on, right? We're still using a little bit of those energy systems. So it's more specific to say cardiorespiratory exercises instead of aerobic. So we use cardiorespiratory exercises to improve our cardiorespiratory fitness. That also makes the language more consistent and make it have sense. So our FIT PV to improve CRF is 5 days per week of moderate intensity, or 3+ days per week of vigorous intensity, or an equivalent combination of moderate and vigorous activities. This is our general ACSM recommendation for our average person just trying to improve their fitness. They don't have a lot of specific goals in mind, just to improve their fitness. Maybe they want to do some 5Ks or something, but nothing, they're not training for a marathon or some other sport specific event. For intensity, so that was the F part. For the I, intensity, if we're talking about moderate intensity, that's 40 to 59% of heart rate reserve. Vigorous intensity is 60 to 84% of heart rate reserve. And either level of intensity is recommended for most healthy individuals. Even with my older adults, I'll get them into the vigorous intensity range. I had one study I did where we had older adults, 65 to 85 years of age, walking for an hour on a treadmill at 70% of heart rate reserve, 3 days per week. And they did that for 6 months. We had to build them up to 70%, but they hit that by 1 month. So for at least 5 months, they were doing that. So most people that are healthy are capable of doing the vigorous exercise. Either level of intensity is recommended for most healthy individuals. I just said that, but that is important. And our method of prescribing exercise intensity are varied and include heart rate reserve, peak heart rate, peak VO2, and RPE. The most common ones are that heart rate reserve and RPE ones. The heart rate reserve, because it's a pretty accurate way, because we're accounting for the person's max heart rate or age estimated max, and also what their resting heart rate is. We get an actual kind of working capacity, if you will, between that max and their resting. And then RP is useful if you don't want to use heart rate with somebody. Maybe they're on a medication that limits their heart rate max, so we don't really know what their max is, or there's some other reason. You may like someone that doesn't have a way to monitor their heart rate, for example, we could use RPE for that. The first T, time. There are substantial benefits for people who do at least 150 minutes per week of moderate intensity, or at least 60 minutes per week of vigorous intensity. There are additional benefits for people who do twice this, 300 minutes per week of moderate or 150 minutes per week of vigorous. So we recommend 150. We know 300 for moderate is still relatively safe. A couple of years ago, I saw a study where they looked at the literature and determined that amounts up to 10 times that 150 minutes per week were still safe, still had benefits for a lot of people. That's a lot of exercise, right? 1,500 minutes per week. That's 25 hours a week of exercise. So not what most of our people are going. We're fighting just to get them in for that 150, right? We're not going to get over 1,000 with them. There are some populations, people that are trying to use exercise for weight loss, for example, where that 300 minutes is more the goal. Second T, type. All types of physical activity are beneficial as long as they are sufficient intensity and duration. We generally consider CREs to be rhythmic continuous exercises that involve major muscle groups. We typically think of walking, running, biking for this. It can also be aqua jogging, swimming, anything where there's a consistent, continuous elevation of the heart rate. Intermittent exercises, interval training, and stop and go sports can be used to accumulate the recommended frequency as long as the individual bouts are of sufficient duration. And by sufficient duration, this keeps changing. We used to say 10 minutes and then 5 minutes. And we're not as strict with labeling it because we still want people to do is whatever exercise they're able to do, whatever exercise they have time to do. So I'd say as long as those bouts are 30 seconds to a minute in duration, if they're going to do 31-minute bouts of exercise, that's still really good, right? I'm sure that's sufficient enough for health benefits. This is table 3.5 from your book, and it just lists the different types of, different categories of cardiorespiratory exercises. So we have endurance activities requiring minimal skill, vigorous intensity exercises requiring minimal skill. And these are things like walking, running, being on a spin bike, and then endurance activities requiring skill to perform in recreational sports. I won't ask you about these categories, A, B, C, D. We mainly care about this with exercise or with some clinical applications. If you are taking the ACSM EP exam, though, there can be a question about these categories on that exam. So if you are doing that exam, then do for that. It's mainly I just want you to be aware that we categorize these based on the skill level and the intensity. And then continuing table 3.6, it just lists some pros and cons of these different common exercises. So walking, jogging, bicycling, and swimming, and aerobic exercise machines. V, volume. Volume for cardiorespiratory exercises is the frequency multiplied by the intensity multiplied by the time to get our volume. This is usually done in METs or kcals. It's kind of a general guideline because, again, we're trying to get that 150 minutes per week. We're trying to make sure it's a high enough intensity. The recommendation would be 500 to 1,000 METs per week. So that one part where it says some combination of vigorous and moderate intensity exercise to meet the recommendations, you could calculate the METs to make sure they're within that. But most of the time, we just kind of eyeball it. If they're doing 4 days, 30 minutes of moderate, and 1 day, 20 minutes of vigorous, they're probably meeting recommendations, right? Or we can do it by kcals per week. P, progression. The rate of progression is dependent on many factors, including health status, fitness, training responses, and exercise program goals. So somebody who is coming to you with light, and you're starting them on light intensity exercise because they're really deconditioned, their progression may be slower than somebody who's young and healthy and used to do sports, but haven't really done anything. Maybe they graduated college and started a desk job and they just took a while to get into a new routine. The progression is going to be different for those groups. Like everything else in their prescription plan, progression is individualized and specific to the individual. Any one or multiple components of that fit of the frequency, intensity, time, type can be modified to increase. So most commonly we increase intensity with people until we get them into a maintenance stage. But we can also do things like, again, people that are severely deconditioned, maybe start them with 2 days per week because they need a little extra recovery time, and then we can increase the frequency. Progression should be gradual to minimize risks. So we usually recommend no more than like a 10% increase, for example, in volume per week to help minimize risk. Again, somebody who's severely deconditioned, we need to go a little bit more than that because you're starting them out so low that 10% is not very much of an increase. And table 4.3 in your textbook, actually, let's save this for the next one. Training.
Let's first start with talking about a research study. This is in your supplemental readings. Anything with a research study that I show you in class is game to be asked on an exam. But if I don't go over it in class, it's not required. Meaning you don't have to read the research paper if you don't want to. I'll give you all the information you need in class. But if you found it interesting or want to read more details or whatever, then it is in the lecture topic folder, but it's optional reading. So let's talk about relaxin and joints. Relaxin is a hormone. It's most well known because it's released during pregnancy. And this is what helps prepare the body for the stretching of the pelvis that needs to happen to get the head through a small space. It's produced by the ovaries, specifically the corpus luteum and the placenta. And it has a lot of effects. It affects not just the structures in the pelvis, but also the rest of the skeletal system, the other joints, the ligaments, can affect the bone, the cartilage, skeletal muscle. It affects a lot of organs in the body. So because of this is one of our precautions we take with pregnancy. We'll discuss that when we do lifespan. So again, important to us for exercise is that relaxin does affect the skeletal system and the muscular system. So in this study, they concluded that female collegiate athletes with a serum relaxin concentration above 6 picograms per mil have a more than a 4 times increased risk for ACL tears. They wanted to know how the relationship between relaxin, or what was the relationship between relaxin and ACL tears. So they took cells from ACL cells from both male and females. This was done during surgeries where they're having the repairs in anyways, took some of the cells from that. They put these in cell culture, and we're going to talk about cell culture a little bit more, but I'm going to start here and just say there's 2 ways that we can do cell culture. We can get our cells either as primary cells, which means we're collecting it from the body and growing it. It's difficult to do. Or we can do immortalized cell lines where we buy these from a catalog. And one of the big differences with this is with the primary cells, like I said, we get them from the body, from the tissue, and we end up with a wide range of donors. When we buy from the catalog, it came from a single donor. It's usually an immortalized cancer cell line. So it's either a cancer cell line. So if you're studying cancer, you can buy these cell lines, or it's cells that have been made immortalized by giving them some attributes of cancer as far as just this unchecked growth. The primary cells are a little more difficult to work with, but again, the advantage is we get this diverse sampling instead of all coming from one person. So cell culture, we take the cells, we put them in a media. That's what this red stuff here is. Depending on the type of cells is going to dictate which one of these vessels we use. Some cells need a lot of space, and we want them to have room to grow. Skeletal muscle cells, for example, that's one where we would do this. Other cells don't want a lot of space, or they don't grow very much, for example, immune cells, and so those we can put into smaller space for them to grow. Once cells get to a certain crowding, let's say, then they'll stop growing, they get unhealthy. We want to make sure that the vessel size is proper for them. So again, back to their research project, they were looking at the relationship between relaxin and ACL tears. They took these cell cultured cells from male and females. That means it's primary. And I'm going to show you a lot of stuff here, but I'm going to summarize it as far as the main point that I want you to know. So they did the male and the female cells. They treated them with different concentrations of the relaxin. And then they thought, well, maybe it's not just the relaxin, maybe it's other hormones that tend to be in high levels in females, such as estrogen, for example. And if you look at this figure, these ones here with the little stars, those are the significant differences between the males and the females. And those were the ones that included 100 nanograms per mil of relaxin, so the higher dose. They did some smaller doses of relaxin, and those were not significant, but the high dose relaxin, whether or not it was with estrogen, did have significant differences between the males and the females. So what the authors concluded was that relaxin's effects on female ACL cells impacts pathways. There was a lot more words, science words they used, but just know that what that meant was it impacts pathways which can lead to collagen degradation and decreased collagen synthesis. Further, this suggests that relaxin plays a negligible role in male ACL physiology. So it was only, relaxin's only having an effect in the female cells because it affects these pathways. So the results of this investigation provide mechanisms by which chronic relaxin exposure can biochemically compromise the integrity of the female ACL by decreasing collagen levels. So again, it didn't act on the pathways of the males with ACL injuries, only the females. Getting into flexibility training, there's 4 types. Static, which is the most common, ballistic, proprioceptive neuromuscular facilitation, abbreviated as PNF, and dynamic. Starting with static, there are 3 types. We have slow and constant stretch with a partner, that's passive. Slow and constant stretch without any assistant, that's self-stretching. And slow and constant stretch against a stationary object, that's isometric. With static stretching, ACSM recommends holding for 10 to 30 seconds each with no more than 4 reps, and that's per joint. So it's not 4 reps total over the body, but fewer than 4 joints, 4 reps for each joint. With static stretching, there is not an increase in skeletal muscle temperature, and there is not blood flow redistribution, unlike with other types of stretching. And your book has some examples of static stretching. We have 2 examples of against a stationary object and 2 examples of self-stretching. Next one is ballistic flexibility. It's rapid and bouncing-like movements. And the resultant momentum extends the joint through the full range of motion. However, we're doing this full range of motion, the myotatic reflex can be stimulated, and as a result, there's high muscle tension. Because of this, we no longer recommend ballistic flexibility. There is flexibility exercises that occur through joint movement. Those are usually dynamic stretches, which we'll talk about in a few slides. And the reason why we don't recommend this because of the high muscle tension is because it creates a higher risk for injury. We want our flexibility training to decrease risk for injury, not increase it. PNF combines passive stretch with isometric and concentric muscle actions. It utilizes the autogenic and reciprocal inhibition responses of the Golgi and then organs and the muscle spindles. There's 3 techniques. There's hold relax with agonist contraction, and then agonist contraction. No matter which of these 3 techniques that are used, there are 3 phases of it. So 3 techniques with 3 phases. There's a passive pre-stretch, followed by a passive stretch, and then contractions. So this is usually done with somebody who's trained in PNF. And so, for example, they would just gently, let's say doing hamstring, they would gently stretch the person's hamstring. That's the pre-stretch. Person would relax, and they would take them into a passive stretch. And then the person would contract their hamstring up against the person, their partner, and for the contractions. It's oversimplified. There's more specific instructions that go along with that, but that's the basic way how that's done. If you want your PNF to be effective, the partner must be properly trained. So like I said, I just gave you very generic overview. You want your person trained so you can do all 3 of those phases correctly. Data is inconclusive, however, if PNF is better than other stretching methods. So here we have the pre-stretch, the passive stretch, and then the contractions. Next one up is dynamic. This is my personal favorite. Slow and controlled sport-specific movements. And this does increase core temperature, unlike static stretching. It enhances activity-related flexibility and balance. We get two for there. We get flexibility and balance with these exercises. No comprehensive list of movements is available. It's up to the coach's knowledge and experience in a given sport. So some examples would be, for those of you that have run or seen some warm-up videos for what people do before running, they do things like called high knees. And so they're running, but they're driving their knees up really high. They're basically, a lot of dynamic stretches are basically taking the movement of the exercise and breaking it down and then exaggerating that. So again, let's use running as an example. So when you run, you drive your knees up, but you don't drive them up, as high as you can. Whereas a dynamic stretch would have people focusing on just driving their knees up, not necessarily as high as they can, but higher than they would go in a normal running step. And they're obviously doing it slower than their running pace for this also. And then their foot comes back and their ankle flicks up a little bit. But again, we'll do an exaggeration with this, and this is called butt kicks. And so the person kind of is going to kind of flip their ankle back again, more exaggerated than they normally would, and almost go back and try and towards their butt. Hence the name butt kicks. We can do this with strength training exercises as well. So for example, if you're doing upper body exercises, maybe it's chest and back day. You can have the person do, for example, like a push-up motion, but even without any resistance, just in the air, and just extending the arms out, getting a stretch through the shoulders, and then bringing their scapula together, like you would do in a push-up, but again, exaggerating. You're not going to have your elbows going behind your chest, but that might be part of the stretching where you would have them do that. So again, not a comprehensive list of motions, up to the coach to kind of figure out what's best for each one. But if you think about it as what the person is doing, how you would exaggerate those activities in a safe way that would lead to some gentle stretching, then that's how we can think about dynamic flexibility exercises. Both static and dynamic stretching can improve range of motion, and the evidence is inconclusive about which technique is more effective. Next up, let's do a little review of the fit for cardiorespiratory endurance, resistance training exercises, and flexibility. These tables are all from your textbook, and they are the official ACSM recommendations for each of these three types of exercise. This is to improve general health, improve general fitness, good for just the average person trying to be fit and go about their daily lives. It helps reduce cardiometabolic renal disease risk, so especially cardiovascular disease, reduce the risk for an MI. It also reduces the risk of developing type 2 diabetes. However, they are not for sports training. For sports training, there'd be more specific details that would be needed depending on the sport and the goals for that sport. And even within that sport, for each position or event, like for example, track and field, swimming, the different events are going to have slightly different training protocols depending what the person needs. But again, most of the people that are just trying to improve their fitness, that are going to the gym, become more fit, this is good for them. So first up is our CRE, cardiorespiratory endurance exercise. Frequency, at least 3 days per week. Remember, the 3 days is if they're doing vigorous. It would be at least 5 days if they're doing moderate. At least 3 days if they're doing some combination of vigorous and moderate. We define moderate intensity activity as 40 to 59% of heart rate reserve,
and vigorous is 60 to 89% of heart rate reserve. Ideally, we want people to accumulate at least 150 minutes per week of moderate intensity exercise. Or some combination thereof of moderate and vigorous intensity exercise. There are additional benefits for the person beyond 150 minutes, but we have really solid evidence that 150 minutes will significantly reduce the risk of developing these cardiometabolic renal disease and improve somebody's health. The type of exercise, aerobic exercise performed in a continuous or intermittent manner that involves major muscle groups is recommended for most adults. So this can be running, walking, biking, aerobic fitness, dance classes if the person is getting their heart rate into the recommended range. Next up, we have resistance training. Frequency, untrained individuals should train for at least 2 non-consecutive days per week. Trained individuals can select a frequency based on their weekly training volume. If somebody's doing split routines or dividing up their body parts, which ones they're emphasizing on different days, then they can do it more than 2 days per week. You know, it's pretty easy to divide into 3 or 4 areas of the body to hit each area of the body and exercise for more than twice per week for resistance training. Intensity, untrained start with 60 to 70% of 1 RM. Trained can do a higher intensity. Volume, we start beginners with 1 set per muscle group. If they're not severely deconditioned, we can move them on to 2 sets pretty soon, like after 2 weeks or so. We don't have to stick them at 1 set for excessive periods of time. In type, we want to do both multi-joint and single joint exercises, as well as exercises that strengthen the core. And lastly, we're going to talk about flexibility. At least 2 to 3 days per week, but daily is most effective. Stretch to the point of feeling tightness or slight discomfort. Hold the stretch for 10 to 30 seconds. In older adults, stretching for longer, up to 60 seconds, may provide additional benefits. There are different types of stretching. So for example, for PNF, we want to do 3 to 6 seconds for the contraction phase and followed by the 10 to 30 seconds assisted stretch. It's recommended to do a series of flexibility exercises for each of the major muscle tendon units. For type, we can do static flexibility, either active or passive, dynamic, and PNF. It mentions ballistic flexibility in this table. I'm not sure why, because ACSM does not recommend ballistic flexibility. It's probably best that we don't do that. We do dynamic flexibility instead.